In this video, we shall learn about chronic obstructive pulmonary disease or COPD. COPD, like asthma, is another obstructive lung disease. It is a progressive condition and it differs from asthma in the fact that there is little reversibility in the bronchoconstriction. It encompasses two entities, chronic bronchitis and emphysema. Chronic bronchitis is a clinical diagnosis defined as a productive cough on most days for at least 3 months for 2 years. Emphysema, on the other hand, is a histological diagnosis defined as destruction of alveolar walls and enlargement of the air spaces distal to the terminal bronchioles. As the two conditions tend to coexist in the same patients, they are clubbed together as COPD. Tobacco smoking is the single most important risk factor for COPD. Other risk factors are environmental pollution and use of biomass fuels, especially in women in Indian villages. Young patients who present with COPD should be investigated for alpha-1 antitrypsin deficiency. These are the symptoms. Most patients have a productive cough, and this may precede frank breathlessness for a few years and is often termed as a smoker's cough. The patient seeks medical attention usually when they start getting breathless. This is worse on exertion and we should try to quantify their exercise tolerance. Wheeze may be present in some of the patients. When breathless, the patient is usually tachypnic and sometimes we may be able to appreciate the use of accessory muscles of respiration, for example, a prominent sternocleidomastoid and intercostal and subcostal recession. Depending on the level of hypoxia, the patient may look cyanosed. As the lungs are maximally expanded because of air trapping in the lungs, the further expansion on inspiration is limited. So this might be appreciated as reduced chest expansion bilaterally. On percussion, they are usually more resonant than normal. Breath sounds may be reduced or difficult to appreciate. Rhonchi may be audible on auscultation. So when we have a patient with a significant history of smoking, presenting with a history of cough and exertional breathlessness, we should consider the diagnosis of COPD and investigate the patient further. On a full blood count, we may be able to see polycythemia. This is a secondary polycythemia in response to the chronic hypoxia. Chest X-ray is done mainly to rule out other diagnoses but may show hyperexpansion of the lung fields. Arterial blood gases are usually done during acute exacerbation. Spirometry is the investigation which confirms the diagnosis. On spirometry, there is usually an obstructive pattern, which means that there is mainly a reduction in the FEV1, the forced expiratory volume 1. That is the amount of air that one can breathe out during the first second of a forceful expiration. So as a result, the ratio of FEV1 to forced vital capacity, that is FEV1 by FVC, is reduced to less than 0.7 or 70%. If the test is repeated after bronchodilation, for example, inhalation of salbutamol, there is no significant improvement in FEV1. And this is how COPD is differentiated from asthma on spirometry by the absence of reversibility. So here you see a normal chest x-ray and you can compare it with this one. So quite clearly the lung fields are hyper expanded. Not only do they look larger, but they also look blacker than normal because of air trapping and hyper expansion. So coming to treatment, smoking cessation is once again the single most important step which will improve the prognosis of the patient. So it is important to emphasize to the patient that if they continue to smoke, their lung function will decline very rapidly. And so we should not only counsel them but offer them all the help in stopping smoking. Now, this is not an easy task for them, and we need to be supportive. And on subsequent clinic visits, we need to ask them about smoking and help them if they need it. In terms of pharmacological treatment, bronchodilators are important. So, in very mild disease, a short acting bronchodilator like a salbutamol inhaler may be prescribed, which they can use as and when needed. However, for moderate to severe disease, a regular bronchodilator therapy is required. So, either we can give them a long acting beta 2 agonist like salmeterol or formoterol, an inhaled preparation of one of these drugs. For example, salmeterol twice daily or formoterol inhaler twice daily. Or we can give them a long acting anti-muscarinic agent like an inhaler of tiotropium bromide, which can be administered once daily. So we have, after short acting beta 2 agonists, we have these options: long acting beta 2 agonist inhalers like salmeterol or formoterol, or a long acting anti muscarinic inhaler like tiotropium bromide. Some patients may require some form of oral bronchodilator therapy like theophylline tablets. If bronchodilators alone are not sufficient, then we can add inhaled steroids like beclomethasone or budesonide or fluticasone to the bronchodilator therapy in inhaled form, obviously. So this is the standard treatment. In severe cases, sometimes they might require nebulization with salbutamol or tiotropium bromide even at home. Those patients who have chronic hypoxia, for example, a PaO2 of less than 8 kilopascals or 60 millimeters of mercury in the presence of features of cor pulmonale, that is pulmonary hypertension and right-sided heart failure, or even in the absence of features of cor pulmonale if they have a hypoxia of a PaO2 of less than 7.3 kilopascals or 55 millimeters of mercury, then these patients should be considered for long-term oxygen therapy at home to prevent further worsening of their pulmonary hypertension. Now, these readings of PaO2 are not during an acute exacerbation, but when they are relatively well. On those occasions, we need to check their ABG, and if they have evidence of hypoxia to the degree that we've just described, then they should be considered for long-term oxygen therapy or home oxygen. When they have acute flare ups, when their symptoms are worse than their baseline level, then they should usually be given a short course of oral steroids like prednisolone 30 milligrams once a day for, say, 1 week. If there are features suggestive of superadded infection, for example, purulent expectoration or fever, then they should be given a course of oral antibiotics like amoxicillin. And before we finish, just a brief review of the management in the emergency room. If they become acutely breathless and come to the emergency department, what can we do for them? So they should be given oxygen in a controlled way because they have a tendency to retain carbon dioxide and they are dependent on their hypoxic drive for the ventilation. So if we give them a lot of oxygen and remove their hypoxic drive altogether, they would start hypoventilating and build up carbon dioxide in their body. So we give them controlled oxygen, for example 24% or 28% oxygen with a venturi meter. Then the mainstay of treatment here is nebulization with salbutamol 5 milligrams, which can be repeated at frequent intervals according to the patient's response, and ipratropium 500 microgram nebulization. During acute exacerbation, they should be given systemic steroids, for example, a course of oral prednisolone, or in acute situations, especially if they cannot reliably swallow, they may be given intravenous steroid like hydrocortisone. Antibiotics should be administered if there is a suspicion of infection. In very sick patients not responding to the standard therapy, aminophylline infusion may be considered. Patients who are in respiratory failure with CO2 retention are candidates for non-invasive ventilation, and occasionally the condition may be bad enough to warrant admission to the intensive care unit. So that was in brief the diagnosis and management of COPD. Thank you.